Thank you very much, Chris, and thank you very much for inviting me here. I always enjoy speaking about evaluation, and I think particularly for the new Care Models programme, we have been extremely fortunate in having a very strong commitment to evaluation, and I hope that during the programme and by the end of the programme we'll have really demonstrated the value that evaluation can bring to this kind of change. This is really about the evidence emerging from evaluation. Sam's already talked a little bit about some of that. So the top question people always ask when you talk about evaluation is, what's the impact of the new care models? And of course that is the ultimate question, but if you could just answer that question, that wouldn't really tell you everything you need to know. All it would tell you is that this new care models programme was perhaps reducing emergency admissions compared to not having a new care model, but it wouldn't really tell you anything about why it's doing it. It wouldn't be much help for people who are trying to follow in the wake of the new care models. You want to know, well, how have they done that? You know, what are the elements which have contributed to the success? So assessing impact is an aspect of evaluation, an important aspect, but the evaluation has also been set up to address a number of other questions that people have asked. And these questions on the left-hand side are the questions that we've heard of during the course of the work we've been doing. So there was an early question in which Sam alluded to, what is the model and how is it intended to work? That was the question that Sam talked about when someone said, that's wonderful, but I don't really know what you're talking about. And I think there was an early stage of the evaluation which was really trying to crystallise what these new care models were. How were the things that were being proposed intended to work to produce the change? That's a very, very important part of it. Then there's obviously an important question, what changes are being made and what is happening as a result? So a vanguard might, or an area might be talking about a programme of social prescribing. But what does that really mean? What changes are being made there? And what are the consequences for patients, for staff, other people? Next question was, what's the impact? We've talked about that. Also important, what's the cost? So you might be having a large impact, but it may actually be a more costly system than before. Or it could be a cheaper system. You need to know something about cost, the resources going in. What's causing the impact? Now that might sound like a straightforward question. Obviously there are a multitude of changes going on. Working out which of those are making a positive contribution and which of those are discretionary, they're making much less of a contribution, is important but quite tricky to unpack. And then the final two questions are really about the ones around spreading. So what should be replicated and spread? Some things which might be causing the impact might be contextual factors within the vanguard. They might be to do with things that other vanguards can't easily copy. So, you know, to do with the kind of configuration of services, to do with the population, the rurality, all those kind of things, much harder to copy. So what should be replicated and spread? What can be taken up, copied by others? And then there's also some very practical questions around how can we implement these things? What are the barriers? What are the enablers? If we want to sort of turbocharge implementation, what do we have to do? I'm not going to go through all the things at the top, but we have several different aspects to our evaluation, and the reason we've got all those is because these questions all require different kinds of tools and techniques to answer them. So everyone probably knows about logic models. They're a very important part at the early stage of a care model. They're basically a diagrammatic way of setting out how the changes you're making are intended to lead to the outcomes you're aiming at. We've got a dashboard, we've got local metrics and national metrics. We've got an independent evaluation. So Manchester University, together with Kent University, have just been appointed to undertake a 4-year evaluation, which is looking at things that we can't easily look at within our rapid ongoing evaluation. So they will look at the wider impacts of these care models. They will look at how other areas are taking up the care models. They will look at impacts on things like inequalities, and a variety of other wider impacts, but also looking at the programme as a whole as a method of change. So what they said to us when we met them last week, Manchester University, was this is a different way for the NHS to do change. This is an important question for us to evaluate. So we can think about this as a method in the future. And then we've got some other learning and impact studies. I'll talk about some of these in the rest of what I'm going to say. So the question of impact and progress. Now, even that is not a simple question. So you can talk about impact at a PACS or MCP cohort level. So overall, are the multi-specialty community providers having an impact? The impact of a cohort depends on the impact of individual vanguards. So you also want to know what's happening in individual vanguards. And of course, the impact in individual vanguards is as a result of the interventions they're putting in place. So I've just set out here vanguards. The first three might be doing intervention 1. The fourth vanguard, it might be a much earlier stage in terms of implementing intervention 1. And we use different approaches to look at the impact at these different levels. So for the cohort level, what we've got here is we're doing national analysis of the time series. So we've got some core metrics we're looking at. We're tracking the progress of those against what would have happened otherwise. So the counterfactual. At the vanguard level, we've got a huge, rich variety of data there. We've obviously got the data from these national metrics, but we've also got data from local metrics. Each vanguard has now got a local evaluation partner, so they've been funded by the national programme to have their own evaluation. They are collecting data on those local metrics, but they're also doing their own pieces of analyses and producing reports to look at perhaps interventions in more depth. And then at the third level down, we've got evaluations of individual interventions. So the evaluators in the vanguards are doing evaluations of particular interventions, but we also have a partnership with the Health Foundation, which we've called the Improvement Analytics Unit, which is using sophisticated statistical techniques to do really robust evaluations. They've got a couple of pilots going on at the moment in the vanguards. So they're looking at Principia MCP, they're looking at the care home intervention there, and they're also looking at the Northumberland vanguard. So we're going to have some really high quality studies of interventions. So just looking at the top level, what we can tell from national analysis. So we set out about 6 different metrics. The ones which we can track most rapidly are ones based on HES data relating to activity in hospitals. So all vanguards talked about reducing emergency admissions and bed days. So this is the kind of approach that we're using. So the green line, actually I'll talk about the red line first. The red line is the trend in emergency admissions per head of population by quarter for multi-specialty community providers. And this is the change, this axis, from the base. So if you look at this top line over here, this is at about 3.8%. So what that's saying is that MCPs have grown. So the quarterly figure for quarter 3, 2016-17, was 3.8% higher than the quarter in the base year, with the base year being 2014-15. So PACS are slightly lower, so that's about 2.2% higher than the quarter in the base year. And the question is, have they done better than they would have done? The comparator there is the green line, which is the non-new care models. So if you look at this data, if you do some further processing of data, you find that the PACS and the MCPs have, over the last year, the growth from the base year has been lower than for non-new care models. This is the data which Simon Stevens was using when he talked at the PAC a couple of weeks ago. That's the kind of aggregate level analysis. But as I said, the important thing really is to understand that, is to understand what's going on within vanguards themselves. So I'm going to talk about a particular vanguard, which is Dudley. Dudley is a good example because there's some really rich evaluation data coming out, and they are extremely open about sharing their data. So they kind of embody the spirit of the programme of openness. So this is their logic model. I'm not going to talk about this in detail, but just to show the structure of it, you've got your rationale for the programme, you've got your priority themes and actions, you've got your intermediate outcomes, you've got your outcomes, and then you've got the overall impacts. And these overall impacts are really the kind of gaps in the 5-year forward view: improved quality and quantity of life for all people in Dudley, an integrated and self-improving system of care. Zooming in on the priority themes and actions, they've basically grouped their interventions into 3 themes: access, continuity, and coordination. So if you look at the coordination line, under there we've got some of the things that they're doing. So they've got multidisciplinary teams, extend and roll out, including risk stratification. They've got an end-of-life care intervention there, training programme, engaging care homes, care plans. They've got new types of workers, and they've got a frail elderly team without walls. So putting evidence together on Dudley, so this is telling the whole story from the national metrics down to what we're getting from the local evaluations. Emergency admissions per capita. So, a bit of an odd picture here. Dudley has increased since the base year by 12.9%, compared to an increase for the rest of England of about 3.3%. But strangely, bed days have actually been reducing slightly more than the rest of England. What this tells us, I think, is that just relying on the national metrics does not really tell us what's going on. We need local interpretation. So this is the change in emergency admissions. This is the percentage contribution of emergency admissions by different length of stay. This is zero length of stay, the blue line at the top. As you can see, its contribution to the overall number of emergency admissions has increased over time. What we think is going on in Dudley is that there's been some coding changes which have meant that A&E attendances in the past have now been classified as short-term admissions. So the headline data basically raises further questions. It's not definitive itself. I mentioned earlier that each of the vanguards are submitting local metrics to us on a quarterly basis. So we've now had 2 submissions. We had one in October and we had one in January. The October one felt something like a kind of trial run. We worked with each of the vanguards then to improve the quality of the data coming in the second quarter in January. Vanguards were told or asked to provide data that they themselves would use to judge the success of their programme. So this shouldn't feel like a new burden that the national team's placing on them. We're asking them to say, how are you measuring the success? And please will you send us the data which shows how you yourselves are measuring that. So this is one of Dudley's many local metrics. So this is unplanned hospitalisations for ambulatory care sensitive conditions, for asthma. So they are using, in Dudley's case, some quite sophisticated approaches. So they're using time series analysis with statistical process control, and they're also using funnel plots. Each of these dots here is a GP practice. And this is, as you can see, these 3 themes, access, continuity, coordination. This is in the coordination theme. This is as a result of some of the multidisciplinary teams and risk stratification that they had as down as one of their interventions. Going down, you remember that chart I had, the cohort level, the vanguard level, and the intervention level. They've also done an evaluation of their multidisciplinary teams. Since April 2014, they've added over 7,000 patients to their registers, and they've done some interrupted time series analysis, which looks at the trend in both bed days, length of stay, and non-elective admissions. Interestingly, what this shows is that this is when the intervention started. The blue line is the continuation of the trend, and the red line is actually what's been achieved, averaged. There's been a reduction in average length of stay as a result of this intervention, they think. That's where the time series started to show a kind of change. For admissions themselves, there wasn't a change, which might seem strange at first glance, but then when you look at what the multidisciplinary teams are actually doing, they are working with people who are, in effect, probably focusing less on the proactive identification of patients at the moment, and what they're doing is working with patients who are probably already under the care of a GP, but they're helping the hospital discharge elements of that. Again, this is showing how the evaluation can really form part of the learning, because I think probably this will show them that to have further impact, they'll want to do more on the proactive kind of case-finding aspects of it. So that's talked about one particular vanguard. This final slide is about how we hope the evaluation will help STPs and areas wanting to introduce new care models. So I've already talked about how it's helping vanguards themselves and helping us shape the programme by learning what's working. I think there are 2 main products. The first are a set of toolkits which are aimed at helping people evaluate change themselves and monitor. This being an incredibly important ingredient for the kind of improvement that needs to go on in developing and implementing a care model. So we've already started collecting together a set of guidance on logic models. We've got some really good learning from the vanguards on how they've used logic models, what they found were the barriers and the enablers. There's a lot of rich learning around the metrics that people are using. So the national data sets available to us are fairly limited for a kind of real-time evaluation. So, for example, the GP patient survey, which is great as a survey, it's a very, very long lag between when the survey happens and when the results come out. And it's not terribly sensitive to the types of changes which are being implemented within vanguards. Lots of the vanguards are developing their own measures of patient outcomes and patient experiences. There's a lot of learning that others can pick up from that. That's just one example. And then the constructing counterfactual, so what would have happened? I think one of my observations looking at vanguards is there's still quite a long way to go in this. Some of them are very, very good at identifying change compared to what would have happened otherwise. I think there are some relatively straightforward things that we can help people learn in that area. And then there are a series of implementation toolkits which we will be putting together, and they'll draw on various aspects of the work that we're undertaking. So learning and impact studies for the elements of the care model that Sam talked about. So for example, risk stratification, the extensivist model, social prescribing. What we're doing is working together with groups of vanguards, so typically around 5 or 6, who are really doing something quite active in this area, and then looking at what they're doing, what we can learn, what the impact is, so that we can distill that learning and write it up and pass it on. I mentioned the high quality impact studies from the Health Foundation and NHS England Improvement Analytics Unit and the Vanguard Evaluator. So the Dudley MDT study is one example of that. There'll be some really nice high quality studies which can show people that this intervention can have this positive impact. And then there are a wider set of evidence summaries that we will be putting together and sharing. And that's the end of what I've got to say. So thank you very much for listening.